Wonderful. So these webinars will also be accessible later via PrEP Watch, so you can go ahead and log on and access any information that we're talking about today on PrEP Watch. So we're going to go ahead and jump in. We've got a lot of people on the line, so thanks again for joining. We're really excited to have you all here for our first PrEP Learning Network launch session. I'm Samantha Dyna. I am part of the Options Consortium and work with FSG, and I'll introduce you to a couple other team members throughout the day. We are going to advance the slides. Okay, so I wanted to give you a sense of what we're going to be talking about today. We're going to spend the first couple of minutes just introducing you to the PrEP Learning Network. What are the goals for the Learning Network? What do we have coming up in the next couple of months, since this will be about 6 to 8 months of learning over the next several months. And we also want to ground everyone in just the PrEP global context. So PrEP rollout today, where are we? So we have a good sense of what we're all talking about. And then we're going to shift to hear from our country partners. And so each of our presenters are from different countries. So we've got Zimbabwe, Lesotho, and South Africa, and they're going to share their stories of the PrEP rollout in terms of the challenges that they've encountered, what's been successful, and just give you a sense of their PrEP rollout journeys. So I'm going to pass it to Christine, who's the project director of Options, which is one of the host organizations for the PrEP Learning Network, to tell you a little bit more about the Learning Network goals and PrEP.
Thank you, Sam, and welcome everyone. We're so happy to have you with us today. As Sam mentioned, we initiated this learning network because we had some experience over the past few years doing learning collaboratives in a number of countries in sub-Saharan Africa, and received a lot of feedback about how useful it was to have a forum where different implementers, ministries of health, and other folks engaged in PrEP rollout and scale up could actually share their experiences firsthand and discuss and troubleshoot specific challenges that they were having. And so that has evolved into this learning network, which will meet monthly or twice monthly through the next year, with the idea that through this forum we can share our PrEP scale up experience, as well as implementation tools and resources, and that this will ultimately support epidemic control by helping countries to achieve PrEP targets. And while you'll see on this slide that it notes a focus on sub-Saharan Africa, I want to say that the Learning Network is in fact open to a broader audience of anyone who is interested, particularly PEPFAR countries, and I know that we have a number of participants today who are from India or South America, and we really appreciate your presence. So, however, the work of Options has been primarily focused in sub-Saharan Africa, and hence that tends to be the lens that that we approach this with. Next slide, please. So, in addition to Options, we have partnered with 2 other USAID-funded projects called EPIC and RISE. Options is in its approaching its 5th and final year, but EPIC and RISE are 2 newly funded projects by USAID that are both focused on providing technical assistance and direct service delivery support to help achieve HIV epidemic control in PEPFAR countries. And so we're very pleased to have this partnership, and so we have tried to pull a mix of presenters on different topics over the course of the next few months, who represent folks working on all 3 of these projects as well as others. Next slide. I think probably everyone on the call is well familiar with the challenges of PrEP rollout. I mean, HIV prevention, we know, is critical to achieving epidemic control, and that treatment alone will not bring us to 0 infections, and that all PEPFAR countries have PrEP targets. And yet, as we have observed in sub-Saharan Africa, there are many challenges, including funding, insufficient facilities and providers, insufficient demand creation, community awareness, difficulty in identifying individuals at risk, poor continuation or persistence rates, difficulty setting PrEP targets and monitoring, PrEP delivery and outcomes, and meeting the specific needs of key populations and adolescent girls and young women. And so while today's session is actually going to not focus specifically on any one of these topics, we decided to launch with 3 countries sharing their overall experience. We then hope in subsequent sessions to dive more deeply into some of these specific challenges. Next slide. This and the next slide are from our colleagues at AVAC, and we just share it as sort of, this slide deck will be a resource for everyone, and so I'm not going to go over this in depth, but just to note that while there was an initial US FDA approval of Truvada for prevention in 2012 and some WHO guidance in 2012 and 2014, most of the advances in PrEP rollout in sub-Saharan Africa. Yes. Can you hear me?
Yeah, I can hear you, Christine.
Okay. All right. So most of the advances in PrEP rollout have occurred since 2016 when the WHO provided normative guidance on offering PrEP for all individuals at system. And then the next slide shows a snapshot of where we are at. You can advance the slide. Right now, in terms of oral PrEP initiations globally, again, the slide is from AVAC. And then I would like to turn it over to my colleague Robin Akel from USAID and PEPFAR to share some specific PEPFAR numbers. Thank you.
Thanks, Christine. Hi, this is
Robin.
I hope there's not an echo on your side. There's on mine. Can you hear me okay?
Yes, there's a bit of an echo, Robin.
Has it gone away?
Yeah.
There we go. Oh, great. Okay. Sorry about that. So hi, everybody, and sorry for the technical difficulty, but maybe we can jump to the next slide. So I'm just going to give a couple slides overview of our rapidly expanding PrEP programming through PEPFAR. So we're in more than 20 PEPFAR countries and counting, and actually these slides were put together in May. So I think even since then we've had a couple more countries launch their PrEP programs, which is really exciting. As you know, we only have right now currently our regular PEPFAR MER data reported every 6 months. So the first 6 months showed that we had initiated for USAID 29,700 people on PrEP in this COP year, which is very exciting. And then we're also following data from our USAID implementing countries on a monthly basis and have seen the numbers grow exponentially even in the last quarter, which is really exciting. But of course, we still have lots of challenges, and those include restrictive policies in some settings. So we're seeing policies still, only covering certain populations or limiting to certain clinics or settings. So we'd like to see that become, not a barrier anymore, or the barriers removed. And then even if there are policies in many places, we're not seeing the policies actually implemented completely yet. And so hopefully that's something that we'll continue to see get better over the coming months and years. We heard a lot about this at the recent AIDS conference in Mexico City, that demand creation and general awareness of PrEP is still quite low. I think part of the issue has been that demand creation is really focused on only certain populations, and again, in only certain geographic settings. In some places, there hasn't been any demand creation at all. And people need to know that it exists and what it is so that they can come and give it a try. And then also, we still are facing, a big need for provider training to ensure that our providers are on board, they're comfortable with prescribing PrEP, and many still think of PrEP in the same context as ART, and I think that's still something that we really need to overcome. So next slide. These are just some data to give you a sense of how the program has grown from 2017 to 2019. 2017 was really the first year well, there were a few countries that started that year, and then 2018 was kind of our big jump in PrEP programming through PEPFAR funds. So you can see year over year the growth, and the 2019 is only through the March. So you'll notice that it's in most countries it's still below the 2018 achievement, but in some countries it's even surpassed the entire 2018 achievement, which is really exciting. And as I mentioned before, some of the OUs or countries listed here don't have results yet, as the programs are just starting and it only started after March. So you'll see more exciting data after we close this COP year at the end of September. Oh, the one thing I wanted to highlight, sorry, just that some countries are behind because of treatment surges, and we're hoping that PrEP is not forgotten in those efforts. So it's something that we want to keep in mind. Okay, moving on to the next slide. So this just gives you a sense of by age and sex. So this is the slide for women, and then the next slide will be men, sort of the distribution across age, the PEPFAR age ranges, where we're seeing PrEP uptake. And so you can go to the next slide. Oh, I think the one for men got cut out. I'm very sorry. Oh, there we go. So this is the one for men. And then the next slide. So this just shows a comparison of all of PEPFAR, where we were with PrEP new by the end of March, and then our new indicator, PrEP cur, which includes PrEP new and anybody remaining on PrEP in the past 6 months. It just gives you a comparison of where they were at the end of March, so the first 6 months of collecting PrEP cur. And it is essentially where we would kind of expect it to see in these earlier days, where we know that retention has been a major, and PrEP continuation has been a major challenge. So we hope to see those numbers grow over time. And I think that's it for me. Thank you, everybody.
Thanks so much, Robin. We had a question come in on the chat from Maureen Luba asking, what are some of the reasons for lack of implementation of PrEP policies?
Oh, that's a really great question. I mean, just to be kind of open and honest about it, I think that there are still a lot of misconceptions and myths about PrEP, and still some thinking that you know, a lot of on the morality issues, that maybe PrEP should not be given to adolescent girls and young women, for instance, or that it'll promote promiscuity. So in some areas, you know, either providers themselves are not implementing the policy, or the district managers, or just depending on how the country is arranged geographically, oversight does not feel strongly about implementing PrEP, so they haven't really enforced it at the clinic level. So there's variability in why and how it's not being implemented. So hopefully that's something we can work to overcome in the coming months in the COP year.
Great. Thanks, Robin. And I see a couple other questions coming through the chat. So we'll take one more now and then jump to our presenters, and we'll have some time at the end, hopefully, for some more Q&A. So Nicole Buono mentioned, Kenya has really done a great job scaling PrEP. Which beneficiaries are receiving PrEP there? KPs, discordant couples, others?
So this is another great question, and definitely true that Kenya has done an amazing job. I can't remember off the top of my head how many sites they're in now countrywide, but it's in the hundreds, if not hitting 1,000 by now. But they started kind of in AGYW, but have broadened out into all populations. Kenya took more of a generalist approach, much like Swaziland Eswatini has done, in more looking for people at highest risk, rather than trying to silo into, you know, specific populations, even though we know which populations are at higher risk, if that makes sense. So I'm not necessarily a Kenya expert, and if there's a Kenya expert who wants to answer that question, I think we have presenters later who will get into that more.
Great. Thanks, Robin, and thanks, Nicole and Maureen, for those great questions. We're going to keep moving just so that we can get into our presentations today. But thanks to Robin and Christine for setting that important context of why we're all here today and what is the purpose of the PrEP Learning Network, and then some important statistics on where we are in the PrEP scale-up implementation today. So I wanted to introduce our three speakers and thank them all for all of the time that they've put into these presentations and spending time with us today. So we've got Definite Namo from PZAT in Zimbabwe, Defarge Akari from Defarge in Lesotho, and Ben Brown from Inova Health Institute in South Africa. And so they're each going to spend the next 30, 40 minutes or so just talking through their scale-up experiences. So where are they at in terms of PrEP initiation and rollout trends today? What's been working well? What's been challenging related to PrEP scale-up? And then what have they learned that they can share with you all on the phone that might be helpful in advancing your work? And just to let you all know, so please use the chat feature while we go through these presentations. We are monitoring the chat, and so this is just a screenshot of where you can get to the chat on Zoom. So we'll be monitoring that, and we have dedicated Q&A at the end of each presentation. So please feel free to chat throughout the presentations, questions that come to mind. We'll also try to unmute folks during the Q&A period. If we run into some background noise, we'll go back to the chat feature, but please feel free to jump in with questions. This is a learning network, so we want to make sure that we have space for you all to engage with each other and understand how you can apply what you're hearing to your programs in your countries. So with that, I'm going to pass it to Definite Namo from Zimbabwe.
Thank you very much, Sam. Good morning, good afternoon, everyone. So I'm going to talk about the Zimbabwean PrEP experience. Next slide, please. Thank you. So in terms of the PrEP program in Zimbabwe, PrEP delivery started with relatively small demonstration projects like Dreams in late 2016. And in 2017, we had more programs start delivering PrEP. And so in Zimbabwe, we have what we call the technical working group that's specifically for PrEP, and it's convened by the Ministry of Health and Child Care, and Pangea Zimbabwe AIDS Trust is the secretariat. So for the PrEP technical working group, it includes various stakeholders, which include the mission in Zimbabwe, PrEP implementing partners, the research community. We also have advocates that are part of the technical working group. We have adolescent girls and young women who are represented as well as other key populations. And in terms of how it's structured in terms of meetings, the technical working group meets every quarter. And the main things on the agenda is we meet to give updates in terms of PrEP delivery, how many people have been initiated on PrEP, what challenges are being faced, where are the gaps as a country in terms of research and implementation science, where could partners really invest their resources in. And one of the key documents that was developed through this technical working group is the implementation plan for PrEP. And the picture there shows the cover page of the implementation plan, which covers 2018 to 2020 and was launched in July 2018. Next slide, please. So in terms of the numbers, what do the PrEP numbers look like in Zimbabwe? So today, as of May 2019, we had initiated about 11,800 people who had ever been initiated. And of those 11,800, we had about 37% of those being adolescent girls and young women. And as a country, we have about 74 health facilities that are initiating PrEP, with a half of the provinces currently providing PrEP. And also with that, we also have, of the 62 districts that we have in the country, about half of those districts have been trained in PrEP delivery. So we have about 350 providers that have been trained to date. And what we are seeing from the National PrEP program is that people are staying on PrEP on average for about 4 months, although it varies. Some stay for less than 4 months, some stay for more than 4 months, but on average, people are staying on PrEP for 4 months. That's what we've been observing. Next slide, please. So in terms of successes, what have we seen from our national program? We are seeing that there is reported high continuation rates of those on PrEP from smaller specialized sites. For example, we have a youth drop-in center called the SHAZ Hub, where we've seen high continuation rates, and we'll hear more of this in future webinars. We'll get a presentation on this. We are also seeing high numbers of people being initiated, and in general, continuation continues to be a challenge generally. And we've seen the multi-sectorial approach being very helpful in the country, where we are seeing the research community, advocates, we're seeing ministry and implementing partners coming together to look at how can we improve the implementation of PrEP. This has really worked well, and having Ministry of Health as a coordinating the technical working group has helped in that. Ministry of Health gets all the information, they look at where the gaps are, and they communicate back to the implementing partners and donors. And also having a phased approach to scaling up PrEP has helped us because as we scaled up PrEP in Zimbabwe, we looked at geographic areas that had high prevalence and high incidence of HIV. We also looked at which populations had the highest incidence of HIV, and we tried to strike a balance between geography and populations with high incidence, and we started with those in those geographies within those populations. And as Zimbabwe, we've also costed our PrEP program, and just to share a few findings from the from this costing exercise, we found that the provision of PrEP to key populations like adolescent girls and young women is feasible and it's quite affordable. This is important because any donor who comes in and wants to deliver PrEP to adolescent girls and young women or any key population, we know how much it costs, we know how much in terms of resources are required to implement that. And we've seen that, that though the cost of initiation are lower, PrEP costs will also increase with low continuation rates. So the lower the continuation rates, the higher the cost. But as continuation rates get better and better, that's how we can improve efficiencies in terms of cost in PrEP delivery. And we also have the Zimbabwe National Communication Strategy that we've developed as a country, and it's running from 2019 to 2025. And just to say, this communication strategy is combining both prevention and treatment and care. And it's going to be launched sometime in September, and we're really excited about this communication strategy. So we'll be ready to share this as soon as it is launched in the country. Next slide, please. So lastly, in terms of challenges, well, we've been experiencing challenges in terms of drug financing. Obviously, the main donors in terms of the PrEP drug in Zimbabwe are PEPFAR and Global Fund. That's where our drugs are coming from. And it would be healthy to have more financing in terms of the drugs. And in terms of implementation, we understand that the different target population, we are still trying to understand how the different target populations are cycling on and off PrEP. We don't have a clear picture of how that is happening, and we're still trying to understand the program data more. And we're also trying to understand how long the different target populations are on PrEP. Like I said before, on average, people are staying on PrEP for 4 months, but we're still trying to understand the data that's coming in more so that we can understand it from the different target populations perspective. And we are trying to understand how we can differentiate models of PrEP delivery to improve efficiencies, because we know not everyone wants to come to the facility every month or every 3 months. So we're trying to understand how we can have differentiated care models around PrEP. Next slide, please. So in terms of key lessons learned, we've seen that developing and using strong monitoring and evaluation tools such as the risk assessment tools and the facility readiness assessments is helpful in making sure program implementation happens according to as scheduled. On the readiness assessment tool, what happens is there's a list of requirements that for a facility, for it to be able to deliver PrEP. And as you go through the facility, one is able, the facility readiness assessment tool, one is able to identify gaps and what needs to happen to ensure that PrEP delivery happens. We've seen that defining who should be prioritized by geography and by target population is important, because we don't have all the resources that we need to deliver PrEP. So prioritization is important. And like I said, for Zimbabwe, we prioritize by geography in terms of where the highest incidence was, and also in terms of target population, which target populations have the highest incidence. And we've also learned that having a strong demand generation program is really important to ensure that communities understand what PrEP is. So you raise PrEP literacy, and communities understand what PrEP is so that they are able to support their peers on PrEP when they go back to the community. And developing an implementation plan is important to drive the implementation of PrEP in the country. And we know how PrEP is going to be delivered when a certain geographic area is going to start delivering PrEP. And investing in PrEP literacy to improve community support, like I've said, and investing in a baseline. For example, in Zimbabwe, before we started scaling up PrEP, we conducted community dialogues where we went across the country trying to understand from an end user's perspective what they understood about PrEP, how they thought PrEP should be delivered in the country. And it's important to understand what it is that the end users expect. And if there are any myths and misconceptions, clarify those before PrEP is actually, you start delivering PrEP. And you develop appropriate strategies for PrEP implementation. And also, it was also important to understand providers' knowledge, address their gaps in terms of in training. So we conducted what we called a knowledge, attitudes, and practices survey, where we targeted healthcare providers. We wanted to understand the knowledge levels around PrEP, understand what their attitudes and practices were, and these were then addressed in training as they were being trained in PrEP. And lastly, having a strong follow-up is also needed to attain high continuation rates. We see this as important, and these are some of the lessons that I thought would be important to share with you today. Thank you very much.
Thanks so much, Steph. We are seeing lots of great questions coming through on the chat, which is wonderful. So we're going to answer a few of these, or ask Steph a few of these during this time. And for those that don't get answered, we're going to go through and see if we can do written responses either in the chat or provide additional resources after the webinar on our additional resources page to help answer some of these. I'm seeing a couple questions come up around retention and continuation. So wanted to flag that our next webinar, September 12th, will actually be on the topic of continuation. So make sure to join that if you have specific retention, continuation questions. So we'll definitely be digging more into that in the next month. We had one question come through around the importance of the demonstration project. So Grace asked, how instrumental were the demonstration projects in framing the PrEP rollout plan in Zimbabwe?
So thank you so much for that question, Grace. Thank you, Sam. So in terms of the demonstration project, Zimbabwe had their first demonstration project in 2009 through to 2014. And this happened among sex workers, female sex workers. And then we had dreams. It was important to have, especially the first demonstration project, because then Ministry of Health had some data that...
Get me something.
So, Ministry of Health... Someone is not muted.
I think we're getting some background noise.
Yeah.
Def, you can continue.
Thank you. So it was important, especially the first demonstration project that happened among female sex workers, because we had we had data that had happened in Zimbabwe, and we had evidence from Zimbabwe to say, is this feasible? Will people take the drug, and how will they take it? So the initial demonstration project was really important. And as we conducted the dreams initially, it was also important for the country to understand whether it's feasible to deliver PrEP among adolescent girls and young women primarily, because when DREAM started, it was targeted at adolescent girls and young women, and I'm sure many people on, most of the people on the webinar are from DREAM's countries. So that was important to gather that evidence, because it was evidence from our country, and we learned a lot of things that helped us with the implementation plan and how PrEP would be scaled up. And even from those demonstration projects, we are still learning, but we had a starting point. So that's, I think that's the point that I want to emphasize, to say, when you have demonstration projects, you have at least you have a starting point on how you can scale up PrEP in your countries. So that's how it helped in Zimbabwe. Thank you.
Great, thanks, Steph. We had one other question come through that we'll ask of you before we move on to our next presenter, and then we might have some time at the end to ask a couple more of these. So Jessica asked, given that nearly 40% of individuals on PrEP are AGYW, what would you say have been the most effective strategies for reaching adolescent girls and young women with PrEP and supporting them to continue on PrEP?
Thank you, Jessica, for the question. Thanks, Sam. So I think what has happened with adolescent girls and young women is attributed to the DREAMS layering, because under DREAMS, most of us will understand it's not just PrEP being delivered, but there is a layering of services that is helping. So as adolescent girls come into the facility, they're not just being offered PrEP, but there's life skills, there's the family module that's also looking at the community, their cash transfers. So there's a lot of layering that's happening, and communities are slowly trying to understand HIV prevention from that adolescent girl's perspective. So I think the layering that's happening under DREAMS has actually helped us to get a lot of AGYWs on PrEP, because they're focusing on prevention. And this prevention is also looking at HIV prevention, which is where PrEP comes in. So it's the layering that has really helped in the country. Thank you.
Great, thanks, Steph. And as Christine just mentioned in the chat, there's a lot more to come from PZAT. On September 12th, our Learning Network webinar will be on the topic of continuation, and Shaz Hub will share their experiences achieving really high retention rates. So more to come on AGYW and continuation in the next couple of weeks. So with that, thanks so much, Steph, for sharing your story. We're going to jump to our next presenter in Lesotho. So Chakari, I'm going to pass it to you. Chakari, are you still on? And we might need to unmute him.
So, sorry, can you hear me now?
Perfectly, thank you.
All right, sorry, I was on mute. So my name is Defarge Akari. I work with JPEGO in Lesotho, and we work with the Ministry of Health to provide pre-exposure prophylaxis at community level. So PrEP is provided in facilities through another partner, and we are responsible for PrEP in communities. So you can move to the next slide. So as JPEGO, like I said, we are the community partner, and our primary target is we've been asked by USAID to target adolescent girls and young women. So that's 90% of our target, as well as female sex workers and MSM. The facility partner has a serodiscordant focused target. So we started implementation of community PrEP in January 2018, which was Q2 of FY18, and we are working in three districts in 3 of the country's 10 districts. So just to give a perspective, Lesotho has a population of about 2 million people with an HIV prevalence of 25.6% and then annual incidence of 1.1%. So we are a high HIV burden country. So in the first quarter of implementation, we started 410 people on PrEP. So that's an average of about over 100 new clients on PrEP. The first month of implementation, we enrolled 50 clients. And by the second quarter of implementation, which is Q3 of FY18, we had a rapid scale up. So we're now enrolling about 500 new clients a month. And by the final quarter of that year, we were enrolling over 1,000 new clients a month. So this is important background when we then start talking about continuation in the later slides. And when we then came to October 2018, which is Q1 of the current fiscal year, FY19, our targets were lower than before. So in the first year, we had a target of 15,000, over 15,000, and now in FY19, our target is below 7,000. So our rate of enrollment went down. We're now enrolling 700 to 800 new clients a month. This continued into Q2 of FY19. And in Q3, which is the quarter that ended in June, we enrolled 1,497 new clients, which is an average of about 500 new clients a month. Can move on. So far, we've enrolled a total of 11,174 new PrEP clients in the 18 months that I'm going to be referring to, which is January 2018 to June 2019. Can move on to the next slide. All right, so this slide shows our age and sex distribution for all of our new enrollments over those 18 months. And where those 11,000 clients have been predominantly female, so we've enrolled 7,681 females and 3,493 men. And as I mentioned before, our primary target are adolescent girls and young women. This represents 90% of our target. And looking at the numbers that we've shown, when you look at 15 to 19 and 20 to 24, the red bars, that those numbers represent a total of 49% of the total enrollment volume. So about 50% of all of the people who have started on PrEP have been adolescent girls and young women. And when we then analyzed our data by quarter, our first quarter of implementation, early 2018, only 29% of the new clients were adolescent girls and young women. And this has since changed to the last quarter that we reported, where 87% of the new clients were adolescent girls and young women. So almost 90% of the new people who are initiating on PrEP are now adolescent girls and young women. And the story behind this is when we started setting up, doing demand creation for PrEP, obviously trying to target young females, they didn't come up. The people who turned up for PrEP were mostly older men, as well as older women. And it seemed to us that it is the men and some older women who are ready to acknowledge PrEP risk, HIV infection risk, and turn up for PrEP. So it took time for the adolescent girls to come out, but they have since been accessing PrEP in the proportions that we were asked to achieve. Can move on to the next slide. So this slide shows the distribution of our new PrEP users by the recognized priority groups for HIV prevention. So like I mentioned before, 49% of our new clients have been adolescent girls and young women, over 5,500. And female sex workers have contributed 9%. MSM and serodiscordant couples have contributed 6%. But the take home from this slide is 35% of the total volumes were people from the general population. So just like HIV infection, which anybody can get infected, we are also seeing people from across turning up for PrEP services. Next slide. So on this slide, it shows a snapshot of where we were at the end of Q3 in terms of progress towards our annual targets. So our target was 6,763, and by the end of Q3, where we would expect us to be at around about 75%, we were at roughly 90%. So, and we expect to meet our annual target during the course of this week. And when you then look at the different populations, we were at 84% of MSM, so we're confident of meeting that target as well. And we had reached our female sex worker target. But for adolescent girls and young women, we had a target of 5,900, and we were at 64%. So we look set to achieve around about 80% of that target. Can move on to the next slide. All right, so this slide shows our 1 month continuation trends over the months since we started. And we track 1 month continuation rates by monthly cohort as a measure of the quality of our service, because we believe that we appreciate that you can start PrEP and stop it when you're not at risk, but we think it's reasonable for you to refuel at least once. So we have, when our numbers were very small, like I said, our first month we only enrolled 50 people, followed by numbers in the hundreds. We had more than half of them coming back for follow-up. But as our cohorts grew, fewer and fewer of them continued PrEP beyond a month. And the lowest continuation rates were recorded in the last quarter of FY18. But the team has gone back and started working on trying to improve continuation rates through better targeting. So this improvement project started in February, and we've slowly gone back to our baseline retention, the continuation levels when clients were so few. And now we've gone above the 50% mark again, and we do this through weekly data review. Our teams go out and extend hours into early evening, and we also now do pre-mobilization. So before, people would be told about PrEP and decide and start PrEP immediately. but now we give people time to think about it, and only if they are ready a week later will they start on PrEP. And we've started calling people 5 to 7 days after starting PrEP to find out how they're doing. Next slide.
Before we move on to the next slide, we had a question come through on what is moonlighting. So if you could define that, then we'll keep moving.
Okay, so by moonlighting, our teams, instead of finishing work at 4 or 5 p.m., they extend their hours to the times when adolescent girls are back from school or back from work, so they could extend their work until maybe 7 o'clock in the evening.
Perfect, thank you. So
this slide shows our project evolving from October. This is using the custom indicators that we report to USAID every month. So we have, if you look at the one on the right, it shows the percentage contribution by type of visit. So the green and the yellow is people coming back for 1 month refill, and the green is people coming back for refills beyond 1 month. So the refill visits accounted for only 33% of our total volumes in October, and this is more than doubled by the end of June to 66%. So more and more clients are coming back to continue PrEP since we started our continuation improvement projects by district. Okay, move on to the next slide. So we have a few successes, and our rapid increase in enrollment was linked to proactive community demand creation, where our teams we use peers. So we have engaged, we realized that we're not the best people to enroll adolescent girls and young women. So the early adopters have worked for us as demand creators, talking to their friends about PrEP and helping us bring in young girls who are at risk of infection. We also had a human-centered design activity with female sex workers to try and see what challenges they were facing in terms of continuation, with positive results. And we have established coping from HIV treatment success of teen clubs. We've established something we called Generation Aspire, where adolescent girls and young women in their first month of PrEP get a chance to meet up with others who have started PrEP at that same time. They share experiences, learn a bit more information about PrEP, and have fun. That group never meets again, but they are asked to join a WhatsApp group, and they interact through that WhatsApp group. This has helped us to retain 60 to 80% of the girls who are involved in this activity. Next slide. Challenges have ranged from concerns from not only parents, but health providers who are concerned that PrEP will lead to promiscuity, and I'm sure you're aware of the other things that people refer to. Our national supply chain might not have been as ready to start giving us drugs for PrEP, so we're using tenofovir and lamivudine, which is also stocked for people who are on this combination for HIV treatment. So we've had instances where we're not given enough drugs. And beyond that, there is a concern that this combination of tenofovir and lamivudine is being produced less, and the country so this is at a global level, so the country is now currently in discussions of trying to move to Truvada. Another challenge we have is, as the community partner, we currently do not provide treatment for STIs. We also do not provide family planning. So we are seen referring these girls elsewhere to get these vital services. ARV stigma has contributed to people stopping PrEP, or some people taking the pills home and never starting. And we also have myths that are evolving in Lesotho, including stories of if you take PrEP, your chances of infection are increased, as well as a belief going around that PrEP makes you gain weight. It's referred to as the appetite pill. We've also struggled to balance convenience and sustainability, so we try to provide our services as close as possible to users, but trying to do this in a sustainable way is a challenge. Next slide. Okay, so our way forward is, like I mentioned, probably transitioning to using Truvada. We've learned about the 2+1+1 PrEP on demand recently from the recently concluded AIDS conference. So for MSM, of course, so this is something that we've started to think of how feasible this will be in terms of implementation. We've started working with village health workers. This is a group that we did not initially want to work with because we thought this would reduce the attractiveness of PrEP to young people. But we realize now that we need village health workers to engage parents to support continuation. And we've now started repackaging PrEP so that it looks different from the ARVs for treatment. And you see a picture on that on our last slide. And as well as advocating for increased integration for PrEP with sexual reproductive health, targeting pregnant women, breastfeeding women, as well as contraceptive users, looking at the results from the recent ECHO trial. And we're also currently finalizing a study collecting data from about 500 of our clients who are currently on PrEP and some who struggle to understand attitudes. Next slide. So some early insights include how to find a balance between engaging parents whilst remaining friendly to adolescents. So parents are definitely needed when that girl needs to continue PrEP. With girls, we've recently introduced point of care testing for creatinine. This is proving to be a barrier, not only for people starting PrEP, but as well as continuing. And when we started trying to integrate family planning on a small scale, there seem to be user concerns, especially with the oral contraceptives and how those work out with PrEP. So some PrEP users are not comfortable with that. And then we've realized that instant mobilization, where we go out and have a community event and people who are interested in PrEP start PrEP immediately, that's good for enrollment, but it's related to early discontinuation. And then our Generation Aspire that I talked about, which is these teen and young women's clubs, they seem to work very well in terms of continuation. And this is linked to social media. Final slide. So this slide is a picture of the repackaging that we have tried to do. So that's a PrEP bottle wrapped in a sticker with our PrEP slogan, and then there's what looks like a lipstick case where a user can pack 7 pills and not have to move around with the rattling bottle. Thank you.
Great. Thanks so much, Akari. There are so many questions coming through on the chat. So clearly a very engaging presentation, and a lot of people have some follow-up questions for you. So I will ask a few now, and then if we have time at the end, we can ask a few more to all of our panelists and potentially follow up in written form for those that we don't answer. So Florence asked, she noticed that you had great reach for female sex workers, and so she was curious, what are the success factors or successful strategies in reaching that key population?
So for female sex workers, we have a partner called Care for Lesotho, and they they've always worked with female sex workers before PrEP implementation. So they work through peer. They have peer educators who are fellow female sex workers, and they go out and they do HIV testing with female sex workers. They work during times that are convenient for female sex workers, and those female sex workers who test negative are then referred to us to start.
Great, thank you. And we've got a few other questions coming through. So one question relates to this last slide, which we're getting a lot of praise for the great work that you've done and this packaging. So a lot of questions coming through on how to differentiate PrEP from ARV and combating the stigma with ARV. So if you have any other context you want to share around this packaging or other things that you've tried to combat that stigma and differentiate?
Okay, so this packaging came from, like I said, we had a human-centered design session with female sex workers, and it was clear that, as well as talking to adolescent girls and young women on other platforms, it was clear that they come for PrEP, they're excited to hear about PrEP, but once they take the bottle home, their friends and family tell them that, look, those are ARVs you're taking. And some of them never get to start. So we realized that the packaging has a lot to do with it. And with by putting this sticker on this, so this is something that we've not done for long. We only received these, I think, a couple of weeks ago, and our teams should have started using this this week or last week. So they put this sticker on the bottle, and our theory is by using this, the girl is going to get less scrutiny, and this is going to look different from ARVs for treatment. And then the one that looks like a lipstick container is, unfortunately, you cannot see the outside, but the outside of it is black. It really looks, it doesn't look like anything carrying medication. And the pills inside do not move around, so there's no rattling, and there are only 7 pills in there. So that's something that is in its infancy, and we'll see how that works. So we're going to track the people who use this to see if they tend to continue on PrEP more than the others. But because of quantities and budgets, we are only using this pill to people who are coming back for follow-up. We're not using it, we're not giving it to new users.
Great. Follow-up on that, Akari, is related to the cost of the repackaging and the pill case. So you mentioned budget considerations and using this only for those in follow-up, but any other context on costs would be great.
May I give you the cost of that by the end of the call? I think Jason is also on the call. He might be able to help with that.
Okay, Jason can jump in on the chat if he has additional context to share. A couple of last questions related to the community refill. Can you talk a little bit more about how the outreach for that worked?
Okay, so our teams, I should have given more details on this. So our teams work from what we refer to as resource centers. So we make a deliberate attempt to demedicalize the PrEP, the whole PrEP thing. So we have resource centers, and then using a hub and spoke model, we have our teams go out in tents. So, and they set up tents at identified community hotspots close to the users. So they work from these tents that are clearly branded with the PrEP signs, and users then come to these tents, and we go to these. We're not available at that spot every day, but we go to these different service points on a 2-weekly basis. And the 2 weeks we arrived at, because our local guideline says once you start PrEP, after 2 weeks, you should go and do your first follow-up. So every 2 weeks, our teams go there to see people who are coming back for follow-up, as well as to start any new clients who are from that area. So it is a mobile outreach approach that we're using.
Great. Wonderful. Thanks so much, Akari. Super interesting. And I know there's still some questions on the repackaging that you showed at the end there. So stimulating a lot of discussion, which will continue on in the chat, and we can follow up if we have remaining time at the end of the webinar to talk a little bit more about this. People were very excited about that, so thanks for sharing. I'm going to pass it to Ben Brown from South Africa to make sure that we give him some time to present and tell his story, and then we can loop back at the end with additional questions. So thanks again, Shikari, and we're going to pass it to Ben.
Hi, good morning and good afternoon, everyone. My name is Ben Brown. I'm a project manager at the Innova Health Institute and have been implementing PrEP research and programming in South Africa since 2008. I've just been asked to represent our organization and our partners at Engagement Health for this presentation today. So I'm presenting on behalf of them as well. And if we just want to advance to the overview slide, like the other presenters, I would like to start by giving just a brief overview of the South African program. But I won't be going into really any detail about the national strategy. I've rather been asked to speak very specifically about the progress we've been making with FHI 360 linkages in our MSM program. So let's just dive right in. In terms of the history of PrEP rollout in South Africa, we really started quite early with clinical trials, specifically in the Western Cape and Cape Town. Right after that, and I think if you can just advance 2 or 3 times, I think there's an animation. Yeah, and one more time, that's great. Okay. Right after the clinical trials finished, South Africa jumped on board with policy very quickly, and that opened the door to allow us to really pilot a variety of demonstration projects that were really population specific and fairly small scale, and those were centralized really in the main cities in South Africa. Thanks to some really strong and insightful leadership in our National Department of Health, we have been able to expand and push a national program since 2016, and that has really been able to grow the availability of PrEP for a variety of populations. So next slide. Great. So I'm not going to go into detail about the national program. This data is a little out of date, but I really just wanted to illustrate the geographic scope of the NDOH's work. And again, to illustrate that amongst the 82 sites on this slide, the majority are really sitting in the Western Cape, in Gauteng, and in KZN, which is really where most of the research and original demonstration projects that targeted MSM and sex workers were based. If we look at the next slide, I don't want to go into the full cascade, but for me, the lesson learned is really looking at the total HIV negative tests, the percent offered PrEP, and then the percent who have initiated. And I think it's just very clear that we still have tremendous opportunity and room to grow in terms of reaching everyone who could potentially be eligible for PrEP in our context. So moving on to the Linkages project. Linkages came in December and have been working quite closely with both Innova and Engagement Health to expand the existing PrEP services that have been available in Gauteng and in the Western Cape, but really with a specific focus to drive the decentralization of PrEP outside of facilities and really upscale the availability of community-based PrEP, which has been a really exciting opportunity for us. And that's happening now in Cape Town, in Gauteng, in Buffalo City, and in Nelson Mandela Bay. So if we look at our progress to date so far on the next slide, we've had a fairly slow start at the beginning of this year in terms of recruiting new PrEP initiations. That had to do with, I think, a lot of regulatory delays and a lot of delays in starting up sites in other parts of the country that hadn't really done a lot of dedicated community-based PrEP work. However, our growth in PrEP amongst MSM has been consistent every single month. And once those sites came on board, we've really seen a tremendous amount of growth month over month and are on track to meet our PrEP new targets for USAID. So I think that's a positive. Moving to the next slide, in terms of some of the implementation considerations that we've had, very similar to some of the other speakers, and what we've really been looking at over the last 9 months or so are the differences between our facility-based program and our community-based programs. There's obviously pros and cons to each of these different strategies. For facility-based programs, we really see consistency in returns and higher retention. We also see MSM tend to self-select more often in facilities. Mobile services obviously offer a tremendous opportunity for growth and for the easier accessibility of PrEP outside of a clinic setting. But similar to what we see in Lesotho, or what was just presented in Lesotho, we also have that challenge of ensuring the sustainability of those services. So once we've deployed, a mobile clinic to support PrEP initiations, we then are obligated to ensure that those services remain available for those individuals so that they're able to be retained into care, into PrEP rather. We don't really see any significant differences in the people who are accessing mobile versus clinic-based services, but the main difference we do see is in retention. Right now, we have, I think for the last 5 or 6 years, consistently seen at least an 80% retention rate at month 1 and above 60% upwards to month 4 for facility-based PrEP initiations. For mobile PrEP, it's been significantly lower. About 30 to 40% of people are coming back after month 1 to stay on PrEP. This is reflected amongst other populations in South Africa. The South African sex worker program has also seen very similar outputs, but it's been something that we've been focusing on quite carefully to ensure that we are keeping that retention as high as possible for people initiating in a mobile space. In terms of leveraging social networks and EPOA, I just saw a question pop up. One of the lessons that I've always pushed very hard is this idea that obviously we engage peers for key population programs. But something I think people often overlook is the fact that just because someone might be a key population peer, it doesn't necessarily mean that they are a PrEP peer. So using tools like enhanced peer outreach, where people who initiate PrEP on our sites are then used to pull in their social networks, have been really effective. I think very simply because it makes a huge difference to be able to speak to someone who's like you, who's also taking PrEP that you know and trust. So we've seen quite a good uptake through EPOA and through working with social networking. It does take an extra bit of effort for our sites to do that, however. In terms of retention, we've always done case management for our newly diagnosed patients in our clinics, and we've now extended that to new PrEP users, particularly those starting in mobile settings, to ensure that we're keeping retention higher amongst those populations. So the next few slides are really just about some marketing and communication strategies that we've really looked to over the last couple of years. So you can go to the next slide. In our experience across a variety of funders and partners. And first and foremost, it's been mentioned before, the real need to demedicalize PrEP. I think very early on, communication messaging across multiple programs was very focused on worrying about people abusing PrEP or over-medicalizing it, or being very, very cautious because it was so new. And I think that really, really prevents people from truly understanding the tremendous benefits that PrEP can have in their life. So we really, really recommend straight to the point, very simple, demedicalized messaging. In the next slide, you can see some advertising from our partners at Out, which I think does a fantastic job of making PrEP pleasurable. It is so, so important that we make sure that people understand that PrEP is something that can connect into their lifestyle, into their relationships, that it's something that can have a very positive and happy benefit in their life, just like we do with condoms, just like we do with other prevention strategies. I think it's a key thing to not take PrEP too seriously in this case. Next slide. This is a particularly important point for communication, is avoiding PrEP stigma. One of the lessons that we struggled with demonstration projects early on that were very focused on sex workers and high-risk MSM is that it then began stigmatizing PrEP for other populations. So we try and find ways to communicate and advertise to, say, young people, but also people who are injecting drugs in a way that reaches them with the information they need without necessarily stigmatizing PrEP or linking PrEP entirely to those populations. Lastly, as a long-term PrEP user myself, this is always my favorite recommendation when it comes to marketing, is really remembering why people want to take PrEP in the first place. And that is really a recognition that for many people, traditional HIV prevention strategies are not working. Others really don't necessarily have choices to empower themselves to use traditional methods of HIV prevention. So PrEP can fit really, really holistically into someone's life. And The more we market to those needs, the more personal we make it, the better connection we make with people, and the easier it helps them to understand the benefits of PrEP, which makes them motivated to not only take it, but to continue to use it. So I'd like to close with 5 lessons that we wished, I think, we had known from the day one of our programs that could be particularly helpful for new sites or sites who are early on in their PrEP implementation. First, it is absolutely essential to consider scale early. I think it was Mitch Warren from AVAC I heard first talk about pilotitis, and this idea that we become very focused on a specific site or implementing PrEP on a specific day or with a specific team. And in reality, there is no way that we are going to reach national performance targets with that approach. It is really, really important that we look at as a large scale as possible from the beginning, or at least a rapidly evolving scale up. I always say PrEP can be easily integrated into existing services. If you're providing ART, you can provide PrEP. Next point, again, is just to communicate very realistically. So one of the challenges I think we've seen is balancing large-scale communication to the general population, but then making sure the closer we get to those high-risk key populations, the closer and more specific our messaging gets about how PrEP can be used in their life. Number 3 is really recognizing and remembering that for some people, PrEP may be once off. I work with a lot of implementers who get very panicked when PrEP users disappear or stop, because there is this mentality, I think, that PrEP is still being implemented like ART, and that's very, very inaccurate. We have to remember and recognize that sometimes PrEP user may use it intermittently, they may drop off, they may come back, it's okay. The 4th point is really emphasizing that programs need to reflect real life. Again, I think we try and overly program PrEP. And the reality is that you can do a PrEP visit in a little bit more time than it takes to run an HIV test. We really need to make PrEP accessible to people's lifestyles, whether that's after work or on weekends, or in a way that's not necessarily clinic driven. You know, if I'm a PrEP user, I'm coming back to get my refills, I might not necessarily want to sit in a clinic full of sick people who are trying to see a doctor, etc. So finding ways to not necessarily so rigorously adapt standard clinical research practices, and more realistically provide PrEP in ways that make it easier for people to do. Lastly, a reminder for us always is that potential PrEP users are everywhere. And I think other presenters have alluded and spoken to this, that PrEP awareness is, for us, still very low, despite the fact that we've been doing it for 10 years. I can still find populations of people who have very little awareness of PrEP. And so making sure that PrEP communication is something that is absolutely standard across all services is really important. And to remember that people who need PrEP might not understand their risk, or they might not necessarily be honest with their risk with you. So it's key that engagement with these PrEP users is empowering them to make these choices and uptake PrEP fairly easily. So I think that's it from me. Thank you very much.
Thanks so much, Ben. So many great lessons learned, and love the marketing strategies that you went through as well. We've got a follow-up question from Maria, who thought it was interesting. We're getting some background noise. Not sure if we can mute those who aren't presenting. Who thought it was interesting that the retention within facilities was better than the community. So Ben, if you have any context that you'd like to provide to answer that question for Maria.
Yeah, I absolutely do. It's something that we've spent a lot of time looking at. I think first and foremost, for a brick and mortar facility that someone is seeking out, it generally is going to be someone who has thought about PrEP, who knows that PrEP is right for them, and they want to take it. And I've always said, if you have an educated person who knows that PrEP is going to protect them, they're going to take it and they're going to come back for it. In community settings, we're pulling in networks of people who might not be as familiar with PrEP, which is a challenge. But also, I think there were early on operational challenges of making sure that mobile clinics were implemented consistently enough that someone who needed to come back for a follow-up visit was able to access a mobile service rather than going to a facility. So that was one problem that has been addressed. Secondly, I think there is still just a natural drop-off of individuals, just like we see in facilities. But the other factor that we've really been exploring as well is this recognition that Are people being pressured into taking PrEP? Are people, coming into the mobile facilities and saying yes to a prescription because, the white coat effect, that kind of thing. We've really worked to make sure that it's a non-pressurizing environment. People are not incentivized to take PrEP. There's really no pressure from teams in order to get that done, but it is one of those possible issues. It also really speaks to the idea of same-day initiation. We've tended to really shy away from same-day initiation, but it's something that has been used in other populations. And I think we heard very clearly in Lesotho, it's the same kind of issue where we really want people to be 100% on board with PrEP before they take it. And in a mobile setting, if someone comes in, they learn, they get offered, they might not be 100% ready for it. So I think there are numerous different lessons to be learned and various different factors influencing mobile retention.
Great, thanks so much, Ben. So we're going to open it up to all of our panelists to chime in on a couple of these questions that were raised throughout. So any speaker, feel free to jump in if you had something to add. So one theme that kept coming up was related to tools for screening for PrEP eligibility. So Def, Ben, Shakari, Christine, or Robin, if you want to chime in on what you found to be helpful in the eligibility screening.
Hi, this is Ben. I'll start. We actually aren't particularly strong advocates for eligibility screening for PrEP. One, specifically because we don't have long queues of people that we're trying to weed through to determine if they should or should not take PrEP. We really keep it as simple as possible, which is, in our context, if you're sexually active, you're at high risk for HIV. So we try and understand if people are having sex, if they understand what PrEP is. And if they would like to take it. And for us, that's really where we draw the line in terms of eligibility assessments.
And thanks. This is Def from Zimbabwe. So in Zimbabwe, we do have a risk assessment tool that we use across the board, across all populations. And the reason why we have a risk assessment tool is to try and see who's eligible for PrEP and who's not eligible for PrEP. And anyone can come in and say and request for PrEP, and there'll be that risk assessment tool will be administered for them. And the reason we have that is also not to put people who do not need PrEP and initiate them on PrEP, because we just don't have the resources to be putting everyone who needs, who says they want PrEP on PrEP. So we need to have some sort of checks and balance to ensure that we are able to quantify how much drug we need for the people who are eligible for PrEP, at least at the present moment. And we are free to share the risk assessment tool. It's also on the PrEP Watch website. Thank you.
So in Lesotho, sorry, this is Defarge Akari. So in Lesotho, we are kind of like the Zimbabwean way, but as we ask the different risk questions, number of partners, condom use, even if somebody says no to all of those risk questions, but at the end, the last question is, does this person still want PrEP? So someone can deny all of the different sensitive questions, but at the end, if they still want PrEP, they get it.
This is Christine. Def, I just wanted to follow up on your comment. So I think, one issue in Zimbabwe right now is, of course, the funding for PrEP. I think that may be a unique situation where there is more demand than availability. But in general, do you really think that, my understanding from what I have observed across the multiple countries is that the worried well are not asking for PrEP, that usually if somebody is asking for PrEP, they probably are a good candidate for PrEP. What are your reflections on that?
Yeah, that is very right, very correct, Christine. Thanks for chiming in. What we are seeing at the facilities is those who come in and request for PrEP are really in need of PrEP, because at times they might say they're in a serodiscordant relationship, they don't trust their partner, there is some sort of risk associated, present in that person's life. And that's what brings them to the facility to request for PrEP. We are still doing a lot of demand generation because a lot of people don't understand what PrEP is. So the people who are coming in are those who really know I need PrEP, and these are the risk factors that have gotten me to ask to request for PrEP at the facility. So you are right, Kristen. Thank you.
Great.
And Martha is going to share a link on the chat to some resources on risk assessment and some thinking around it, and also some tools. But I kind of agree with Ben that I get nervous about using risk assessment tools just because I don't think I think that people self-select pretty well.
Great. Thanks all for weighing in on that. One other question that kept coming up in the chat was around integration with STI and family planning services. And that's something that, as Christine mentioned, we're looking to have a separate webinar session specifically devoted to that and what's been effective in integrating PrEP into other settings. But if our webinar participants that we have on the line today want to chime in with anything that's been particularly effective in those settings, I'm going to open the floor to you all.
Yeah, so this is Ben. I'm not sure if it's at all particularly innovative, but we really only provide PrEP in the context of comprehensive sexual health services, including STI treatments. We don't really do testing outside of HIV and syphilis, so everything else is really symptomatic. I don't have the data in front of me in terms of how many people have come in for STI treatment and left with PrEP, but they are all obviously counseled and offered PrEP when they do come in for STIs. We also use it as an opportunity to address concerns with condom use in PrEP in particular, so that, you know, for people who aren't using condoms as regularly, they are being regularly screened and treated for STIs. So in some ways, it's a really great way of diminishing the bias and stigma against condomless sex amongst PrEP users.
This is Dave. So in Zimbabwe, there was a small demonstration project that was conducted by CHAI. I don't have the specific results to that, but I'm sure CHAI can share even on this platform as well. They did a small demonstration project where they delivered PrEP within the family planning sites in Zimbabwe in 2 facilities, one urban and one rural. And the sample size was about 150, but I don't have the exact outcomes of that study. Maybe they can share at some point.
Then for Lesotho, as I indicated during our presentation, our ideal model was to have PrEP provided alongside family planning and STI treatment, but due to failure to get access to these commodities from the Ministry of Health, who is our main partner, we have not been able to. So all we do is screen for STIs and refer, and as well as discuss family planning options and refer. We do provide condoms now.
Great. Thanks all. And we're getting a couple of questions related that kind of vary by country related to PrEP requirements. So if you could all speak to the creatinine requirement, PrEP use in pregnancy, and the age for PrEP and how that looks in your country, that would be helpful for our participants.
I'll go first. So in Lesotho, I think you mentioned 3 things: age, pregnancy, and creatinine. So in Lesotho, yeah, we as a project, we target adolescents from the age of 15 upwards, but the ministry has not stopped us from providing PrEP to anyone who is below the age of 15, as long as they are sexually active and above the weight of 35 kilograms. They can, if they can receive tenofovir, they can do that. So the only other thing that would be a barrier is consent for HIV testing. So in Lesotho, you can get tested for HIV without parental consent if you're older than 12. And then for pregnancy, our guideline is clear that PrEP is safe in pregnancy, and there are no pregnant women are not treated any differently with regards to creatinine thresholds.
This is for Zimbabwe. The creatinine test is recommended but not required. So people can be initiated on PrEP without creatinine clearance. Where it's available, it's recommended that it's done. And in terms of the age, our legal age of consent is 16, and from the age of 16, people can also access PrEP. And as for pregnancy, PrEP is not contraindicated in pregnancy in Zimbabwe, so even pregnant people can be on PrEP. Thank you.
Hi, this is Ben. I think everything is pretty much the same for us. The only thing I would add is that we are working on really reducing the number of creatinine checks that are necessary over the year. We found it to be, a huge waste of money and time generally if people are starting who are pretty healthy. So that is either already out or coming out soon to really, really minimize the number of creatinine tests.
Great. Thanks so much, all. Going to shift to our wrap up. I want to just thank again our speakers, Defarge Akari, Ben, Christine, and Robin, for setting the stage on the PrEP Learning Network and talking about PrEP rollout today and sharing all of your stories. This has been great, and just appreciate all of the participants' great questions and engagement. So a lot of questions coming through today on PrEP continuation. What are the interventions that are supporting PrEP continuation? How are we defining the denominator in retention? So all of these are great questions that we're going to dig into more on our September 12th session. So please save the date for that. The registration page is open. And September 26th, we're going to talk more about mass media. So demand creation will be the topics for September 26th and October 10th, both of which were questions and topics that came up today. So save those dates. We have a lot of great things coming up in the next couple of months. Okay, and we have a page on PrEP Watch that has all of the Virtual Learning Network webinars, so you can register for upcoming webinars there and access these recordings. After each webinar, too, we'll put up additional resources that were mentioned today, additional tools, and other research that might be related. So you can access anything that came up today during the webinar on the Virtual Learning Network page on prepwatch.org. And to close out, we're going to launch a poll. So if you could all just let us know what you thought about today's session in terms of what you learned and its application to your work today. We'd love to get a sense of how it was helpful so we can continue to refine and make sure that these learning networks are facilitating learning for you all in the future. So we'll leave that poll up. So if you could go ahead and tell us what you think, and then we're going to wrap it up. So thanks again to all of our wonderful speakers for answering all of these great questions and providing context. And thanks to our participants for being really engaged and asking great questions. And with that, yes, thank you all. We'll wrap up. Have a great rest of your day, everyone.
Thanks.
Thank you.